Alright, let's dive right in. I'm Dr. Kaazmi, and today we're tackling a medical mystery that is just as puzzling as it is dangerous. We're calling it the case of the hidden acidosis. So, picture this. You have a child in the ICU. They are clearly critically ill. You run one of the most basic fundamental tests, and the blood pH comes back at 7.4. I mean, that's textbook perfect, but you can see that something is deeply wrong. So, how is that possible? How can the body be in a full-blown crisis when its most basic chemical signature looks totally fine? That's the puzzle we're going to solve together today. To even begin to crack this case, first we have to get a handle on why this balance is so incredibly important and why a normal number can be so deceptive. You can think of the body's pH like a tight rope walker. It has to stay within this incredibly narrow, precise range. If it leans just a tiny bit too far in either direction, all sorts of critical systems start to fail. Things like oxygen delivery, electrolyte control, even the heart's basic ability to beat properly. It all gets thrown out of whack, and for a sick kid who's already under a ton of stress, keeping that balance isn't just important, it's literally a matter of life and death. So, when doctors have a gut feeling that something's off with this balance, they do what any good detective would do. They start by checking out the usual suspects. And at the very heart of this mystery, you've got the two opposing forces. First, there's acidosis. That's any process that's trying to pull the pH down. Then you have alkalosis, which is any process trying to push the pH up. Just imagine them in a constant tug of war, fighting for control. This right here, this is basically the investigator's rule book. It's the set of clues you start with. So, besides the overall pH, doctors are zeroing in on two key values. You've got P-COT4, that's carbon dioxide, which is your respiratory clue. It tells you what the lungs are up to. And then you have HCO3 or bicarbonate, and that's your metabolic clue. It gives you a window into what the kidneys and the rest of the body's metabolism are doing. And this leads us to the first big investigative step. There's a really simple but powerful rule of thumb. If the pH and the PCO2 are moving in opposite directions, the problem is probably coming from the lungs. It's respiratory. But if the pH, the PCO2 and the HCO3 are all moving in the same direction, well, that tells you to shift your investigation over to a metabolic cause. But here's the massive twist in our case, right? The pH is normal. That first most important clue seems to be screaming that everything's fine. So, case closed, investigation over. No way, not even close. It just means we have to start digging a whole lot deeper. Okay, so now we're moving into the next phase of the investigation. This is where we start searching for a clue that isn't just sitting there on the surface of that first report. Think about it. When your main piece of evidence, the pH, is totally misleading you, a good investigator has to look for what the numbers aren't telling you. So, how do you find a problem that's actively trying to hide? Well, you do it with a really clever tool called the Anion Gap. Now, this isn't something you measure directly. It's a calculation. You take the main positive charge in the blood, sodium, and you subtract the main negative charges, chloride and bicarbonate. And what you're looking for is a gap, a space that must be filled by other unmeasured negative charges. And in cases like this, those unmeasured charges are almost always acids. And this right here leads to the absolute golden rule of this entire investigation. A high anion gap always means there's a metabolic acidosis happening, period. Even if the pH looks perfectly normal. It's the forensic evidence, the smoking gun, that proves the body is fighting off some dangerous hidden acid that we've just uncovered. So, what could be causing it? Well, the list of potential culprits is pretty long, and doctors often use the mnemonic mud piles to remember them. It could be anything from kidney failure, what we call uremia, to diabetic ketoacidosis, a toxic substance like antifreeze, or even a bad infection causing lactic acidosis. Finding the high anion gap doesn't solve the entire case, but it tells us exactly what kind of crime scene we're dealing with. So, we found our hidden culprit, a metabolic acidosis. But this actually just makes the mystery deeper. If there's a powerful acidosis, why on earth is the pH normal? Well, it turns out our main culprit might not have been acting alone. Let's go back to that pH balance and think of it as a seesaw. This high anion gap metabolic acidosis we just found is like a really heavy weight pushing one side of that seesaw way down, trying to make the body acidic. But we know the seesaw is perfectly level, right? The pH is 7.4. So logically, if something is pushing it down with that much force, something else has to be pulling the other side up with equal force to keep it balanced. We're not just looking for a single culprit anymore. We're looking for an accomplice. So how do we prove there's an accomplice at work? With another slick little calculation called the delta-delta ratio. Basically, by comparing how much the anion gap has changed to how much the bicarbonate has changed, it lets us check if the story adds up or if there's another secret player on the field. In very simple words, in delta-delta ratio, first you take the patient anion gap and subtract 12 from that anion gap value. Then you subtract patient actual bicarb value from 24 and then you divide the first value from the 12. For example, if patient has anion gap of 28 and serum bicarb value of 12, then 28 minus 12 is 16 and 24 minus 12 is 12. And then if you divide 16 by 12, the value is 1.3. And here it is, the smoking gun. If that ratio comes out somewhere between about 0.8 and 2, it's just a regular straightforward acidosis. But if that ratio is greater than 2, that's it. That is definitive proof. There is a second hidden metabolic alkalosis that's pulling the pH back up. That's the accomplice. That's what's been masking the severity of the whole situation, creating this dangerously false sense of security with a normal pH. But the investigation can actually go one level deeper. For the really complex, tangled up cases, experts have an even more powerful tool that gives them a more complete picture. It's called the strong ion difference, or SID. It's a more advanced way of looking at things that considers the entire electrical balance of the blood, not just the big players. And this approach brings in two often overlooked characters. One is sodium, that is the main positive charge contributor, and then chloride, which is the main negative charge contributor. The strong ion difference is the difference between serum sodium and serum chloride. It should be between 3640 and very ideally be 38. So if somehow the chloride increases, then it increases the net negative charge, like in overzealous fluid resuscitation, and value will become less than 36. The body tries to balance this over negative charge by increasing hydrogen ions, and hence it leads to acidosis. Similarly, if the chloride ions decrease, like in vomiting, then the strong ion difference will be more than 40, and it means that there is more net positive charge, and body neutralizes it by increasing negative ions like bicarbonate, and hence that contributes to alkalosis, like what you see in a typical hypertrophic pyloric stenosis. All these calculations, the anion gap, the delta-delta, the strong ion difference, they're all just clues. They're tools to help us figure out the real problem. The goal is never just to make the numbers on a lab report look pretty. The goal is to figure out why the numbers are off in the first place. Is it the kidneys? Is it an infection? A toxin? And then you treat that underlying disease. That's the only way to truly solve the case and to actually help the patient. So, a number that looks perfectly normal on the surface can be hiding this desperate complex battle happening underneath. It's a secret code written in our own blood chemistry. And it really makes you wonder, doesn't it? What other invisible signals are doctors learning to read every single day to solve these incredible life-ordinary puzzles? Anyway, that was all about reading blood gas results. Hope you have learned to decode a blood gas result. Let me know in the comment section. Have a great day. Bye.